Good morning, everybody, and welcome to the 2025 expansion webinar series. My name is Cameron Burkeen. I am the project manager for the Purchase Health Department located in Paducah, Kentucky. It's far western Kentucky as you can get. So for our topic today, we have the emerging threat of xylazine in the drug supply. We have our presenter, Sue Clark-Levin. She is the outreach educator for Advancing CT, also known as Connecticut Together. So as her bio states, Sue Clark-Levin is started out in the HIV and HCV field 35 years ago as a counselor and educator in New London, Connecticut. For the past 17 years, she has been working in the harm reduction field as a syringe exchange worker on a needle van in Hartford, Connecticut. Her mission has always been to support the clients at whatever level they are at in their recovery. So we do ask everybody to use the chat button to feel free to introduce yourself, where you might be located. But we do want to utilize the Q&A feature that is located at the bottom of the screen to submit any questions, because at the end of the presentation, we will have some time left over to direct any questions to Miss Sue, and hopefully she can get those answered to us. So we do ask everybody to remain muted, and at the end, also, if you have any questions, you can raise your hand as well. So without further ado, I'll go ahead and turn it over to Ms. Sue Clark-Levin to talk about the emerging threat of xylazine in the drug supply. You're muted right now. If you could just unmute.
Okay, I'm on a screen where I was looking for the slides and now I can't get back to Zoom.
Okay, well, we can see you right now, so
Oh, you can see me? Okay,
and hear you. So
then,
if that
then
doesn't
let's,
bother you, then you can just go ahead and start.
doesn't
But
bother me at all,
okay.
actually. All right. Thank you so much for having me, Cameron. I'm really, really honored to be here, actually. Cameron and I met online discussing xylazine mostly. And I wanted to start out, before I get to xylazine, I wanted to start out with, since I've been in the field so long, with the additives from way back, which were uh, harmless additives, salt, sugar. This is to the heroin supply, when there was a lot of heroin. Never a pure amount, but enough that it was heroin back then, which so sugar, cornstarch, all those relatively harmless additives is what started many, many years ago. The first giant change was probably the fentanyl, which happened maybe 10, 15 years ago and is built up to the point where it's about 98%, at least in our area, of fentanyl. Um, It's a synthetic opioid coming from China to Mexico. Very, very popular because it's an intense high. It enhances the heroin high. Um, and people originally, we gave out fentanyl test strips on our needle van. People originally were avoiding fentanyl because of the intensity and the spike in overdoses. Uh, they were testing their product and either slowing down or trying to, take less of it. In other words, trying to avoid it. But as time went on, it evolved into a very popular uh, drug additive. And now they're basically using our test strips for the opposite, to make sure that their supply has fentanyl in it, which is kind of interesting and scary. So that actually has been going on. The fentanyl in the drug supply has been going on for a number of years now, as you know. Also, it's in powder cocaine, crack cocaine. So when it first came out in our area, the fentanyl being really popular or being really in all the drug supply, I don't think users were aware that it was in the crack supply. So many, many crack users were dying of overdoses because they weren't carrying Narcan, thinking that that was an opiate problem, not a cocaine problem. So that has since changed. When everyone realized that the fentanyl is in the cocaine product and in pills, so now it's just everywhere and devastating. Then along comes xylazine. Just when we think it can't get any worse, along comes xylazine. Xylazine has actually been around for a number of years, originating in Puerto Rico back in the 2000s. It didn't really hit mainland United States probably until maybe 10, 15 years ago. You still didn't hear too much about it. But as often happens, it seems to hit in Miami, moving up to Philadelphia, and then moving up to our area in New England, then going south and then west. So Kentucky is kind of southwest. So everything, of course, does get to you, gets everywhere. It just see the trajectory seems a little different. A lot of your product, drug supply, is coming from over the border in Mexico through Southern California by truck. So the whole United States is affected, obviously, but by different means of the supply arriving. When it hit Philadelphia, this xylazine, a number of years ago, the doctors didn't know what to do. People were dying left and right because they weren't familiar with this kind of drug. It's not an opiate. It's an analgesic, meaning a painkiller of a sort, but it's really an animal tranquilizer used by vets for large animals, horses, so forth, cows. It's a muscle relaxant. It suppresses the central nervous system in the body. It lowers the heart rate to 20 beats per minute versus our normal 60 to 100. So you can imagine what 20 is like. The doctors couldn't save people. This was Philadelphia. They had a really big, they were hit with it really badly a few years back. They realized once they got them in the hospital that the aim was to increase their heartbeat and so forth. So some were saved, but many were lost before they could figure it out. They just thought it was a very bad fentanyl heroin overdose. Then xylazine, as I said, started spreading, further north, further southwest, when now it's in all 50 states. The problem is the toxicology reports don't reflect that in many states. They're not testing for it yet. Maybe a lot of the information that I give you is changing rapidly by the day. But as of the last 6 months, the toxicology reports weren't reporting xylazine in the numbers. Not, in other words, every overdose wasn't given a post-mortem toxicology report. Now they're, of course, much more aware of it, so they probably will be. Xylazine also is not listed as a controlled substance because it is used by vets legally. Many vet supply companies were hit. It was stolen from many, vets. That's another big problem. But mainly in China, they have the chemicals in their labs, figured out how to manufacture it using legal substances that then turn into illegal drugs and then sent to Mexico. And Mexico has labs that actually do the same thing. And then they're transported out to all the different states by plane, boat, depending on your geography. The effect is so similar to heroin and fentanyl that xylazine wasn't really noticed right away as an additive. In other words, that slow sedation, slow heart rate, relaxed feeling was very desirable. And they could use less heroin and even a little less fentanyl because now the xylazine is lasting longer. Fentanyl only lasts in the system a few hours. Xylazine can last 4 or 5 hours. But if too much is taken in, the person can become unconscious and have terrible withdrawal. The withdrawal from xylazine, although it's not an opiate, is a very powerful, very strong, unpleasant withdrawal, even worse than an opiate withdrawal, they say. So a lot of people didn't recognize it right away as something new in the drug supply. It just seemed like maybe a lot more fentanyl or maybe some more heroin. The interesting thing about heroin is, as of about 3 years ago or so, and I'm not sure where this is in the United States, I just know that in Connecticut, in our area especially, which is Hartford is a capital of Connecticut. So it's one of the three major cities with the highest drug overdose, highest drug use area. Um, there is barely any heroin in the drug supply in the little bags, but there is fentanyl and xylazine. Fentanyl, probably 98%. Xylazine is getting up there. And then the other additives that I mentioned, a little bit of methamphetamine that never really caught on big in our area, but the other two. But I just think it's amazing that the heroin is just about extinct. Um, my personal opinion is that the poppy fields and manufacturing heroin, because it's coming as morphine and then from the poppy plants and then has to be processed into heroin. It's just a lot of work when this is so much easier for drug dealers, drug suppliers, the cartel, is to make in a lab chemicals put together in small packaging, easier to get into a truck or into a plane and to hide, in other words, to transport. And I think that is just going to be forevermore the new face of the drug supply, using chemicals cheaper, much, much cheaper than a kilo of heroin compared to a kilo of fentanyl or xylazine is, there's no comparison. And you only need small amounts, obviously, because they're so powerful. Xylazine is incredibly powerful. You can imagine the size of a horse compared to the size of a person. um, Bad thing about xylazine, beyond the fact that it is not an opiate, so it's very hard. You cannot reverse a xylazine overdose with Narcan, but you can, of course, because it's with fentanyl, you can reverse the fentanyl or heroin part of the overdose. So you can somewhat reverse the overdose. You can begin to, but it's more important than ever because xylazine being affecting the person so strongly, it's more important than ever to get the person into the hospital because that part will not, the Narcan will not do anything to remove the xylazine, as it will remove the fentanyl, from the receptors on the brain, and the person can maybe become conscious, but still struggling terribly because it relaxes all the parts of the body, relaxes the tongue to the point where it, blocks breathing. So now, I remember in the old days, one dose of Narcan would reverse the heroin overdose. That was before fentanyl. Then it got to be we needed 3 or 4 or 5 or 6 because of the fentanyl. Now with the xylazine, people are using more and more and more, but it's not working because the xylazine, as I said, is not responding to it, and they really just need to get into a hospital. We try to impress upon people, clients, that now is more important than ever to call 911 and to get help, because 911 was always thought of as police. But thank God the police know enough. They come upon a scene. They understand that this is there's drugs. There are drugs on the scene, but they understand it's a reversal. It's a overdose reversal. They do not arrest people and they do not even hassle people. They kind of stay to the side. The main people are the EMTs or paramedics that come and help. But if you could just make sure that people understand that they might not wake up if they don't get to a hospital. The doctors in the hospital are little by little understanding more and more what they need to reverse a xylazine overdose, meaning get that breathing up, get those heartbeats back up. So that's really important, for people to understand. So as I started to say, the other downside to xylazine are these terrible abscesses, wounds that develop. The doctors think that maybe why do they develop when the xylazine enters the body and not just by injection? If it could enter the body by pills, crack, smoking, snorting, whatever. Xylazine entering the body cuts off some supply, some chemical in the body that doesn't allow the blood supply to get to the skin. This is what they theorize, and that's what causes these abscesses. And the abscesses are pretty bad. If they're first ignored, which they often are, they will start to open up. They will start to ooze. They will start to turn different colors, yellow, purple. They will deepen, and I've seen them go through to the bone, and it's really, really scary and dangerous. And then the skin will start to turn black because the skin is dying. And at that point, they usually can be talked into going to the hospital to get the skin debrided and treated and, dressed, the wound dressed. Before that, people walk around with the wounds a lot because the treatment that they get in the local hospitals is pretty bad at being drug users. Hospitals, not all, but many of them don't treat the clients well. So they avoid that. And also, it could be hours waiting to get treated, waiting to get waited on. But the wounds that we see are probably in about 2/3 of the clients that come. Why don't the others get them? It could be that their xylazine is not 98% like fentanyl in the drug supply. It's way up there. It started at like 25, then it went to 36. These are from the reports that I get from the toxicology lab at the public health, local public health sends us every few months information on what's in the drug supply. And we, of course, relate it to our clients. Some people, like I said, don't get these wounds, but those that do, if they show them to us, I mean, we do ask, but if they show them to us and we can show them what treatment really does work, because I've seen it work, there's usually a good outcome and they start to improve. But if they don't, that's when it starts eating away through to the bone. I've seen amputations. I've fingers. The interesting thing is they do not appear usually on the injection site. They appear on the lower arms, hands, lower legs. Once in a while, face, but nothing to do with the injection site. It's just more like it just comes to the skin in those areas for some reason. Our number one recommendation for the wounds is moisture. Kind of the opposite of what most people think. They've been walking around all day or they've been whatever, they're leaving their wounds to the air. Kind of like what we heard when growing up. Oh, you need the air, the sun, that's going to dry up, whatever cut you have or wound. It's actually the opposite with these wounds. You want moisture. You want moisture around the clock. So what we give them is these Xeroform pads that are petroleum jelly pads to put on the wound. They can stay on for 3 days, and then we wrap gauze around them to hold them in place. Then in 3 days, they take it off, clean with sterile water, clean the area, soap and water, or at least sterile water, if nothing else. Then they redress the wound. If they run out of those pads, which they could easily do or don't have a chance to come back and get more, we give them a big jar of petroleum jelly, because actually that's what it is. That jelly keeps things moist and it adheres to the skin. So we just tell them 24/7. And I've had them come back like in 7 days after they tried that on beginning wounds. They were holes starting to go bad, but not bad yet. Those kind I've seen improvement in a week if they keep that petroleum jelly on, for 20 round the clock. Um, Often, though, well, not often, but I have seen wounds from the knee to the ankle on both legs, like a foot wide and 2 feet high. It's just, those are ones that were never, ever, ever attended to. But when it gets to the point where they can't walk, literally can't walk, they go to a hospital, and the nurses now, the doctors know how to treat these wounds because xylazine has been around long enough for them to do that. So that's good. But it's a long, long process. It can take months or a year to fully heal the skin because they become so deep, the layers so damaged. It's really a terrible downside, to this drug, beyond being impossible to use Narcan on, which is another important thing that's a downside to it. Usually the drugs, start, or as you probably know, with the cartels in Mexico, South America too, coming up either by ship or by truck, by private car, by airplane, by submarine. You've even heard that, I'm sure. Um, a lot of it cannot be diverted. Everyone can't get arrested that's transporting because they're so clever in how they, hide it. The pieces of the drugs, or the packaging is so small, uh, easy to hide. So it is going to, get into the system. And they're saying, I was reading on a DEA site, and every state has two cartels working. Um, they are working with local gangs to distribute. It's just, impossible to stop. So the way I look at it, our job is to help them get into, detox and treatment if possible, because this is like the worst time to struggle with addiction, struggle with drugs. With It's only going to get worse. The chemical, but there's other drugs that I'll mention in a minute coming down the pike that are bad, but it looks like fentanyl is definitely here to stay. Xylazine looks like it's going to be here to stay also because it's easy to get. They can get it on the dark web also. They can make it easily in a lab, like I said. So it's just the worst time. And not that it was ever a good time, but now it's getting worse and worse. The problem, though, with our area is big on medicated assisted treatment, MAT. That would be Suboxone and methadone. Very, very big. Very, very popular. Not always successful. Everybody responds differently. The problem with xylazine related to methadone and Suboxone is it doesn't work as well. It works better on opiates. It was designed for opiates, opiate, withdrawal and detox, and also going forward, fulfilling the need for the opiates. So it's kind of like the whole drug world is going to be changed by xylazine in that, number one, the Narcan has to be another antidote for this overdose reversal for xylazine reversal, has to be another kind of medicine instead of naloxone. And the scientists are working on it. I think Philadelphia prompted it when they lost so many people so fast to this animal tranquilizer that they're realizing, and they do have ideas, what would be a good antidote. I'm using the word antidote. I'm not sure if that's correct, but a new Narcan would be wonderful. That's definitely got to happen. Also, detoxes have to lengthen their stay. I remember when detoxes were 3 to 5 days, then they were 5 to 7. Now they really need to be 7 to 10, if not longer. Even when fentanyl came, a lot of clients were saying, I went to detox, but I came out in 2 weeks and I was still sick because fentanyl is so intense. So with the xylazine, as I said, that they're not really sure exactly how to treat it. The withdrawal incredibly is worse than the heroin withdrawal. High agitation, high blood pressure, sweating, similar to an opiate withdrawal, but for some reason more intense. Maybe because the xylazine is such an intense, powerful drug, although so is fentanyl. So I'm not really sure, but many studies have shown that a withdrawal from xylazine is even tougher on the person trying to withdraw. So detoxes have to readjust a bit. And I'm sure that would follow with treatment programs because someone leaving detox, usually it's not enough. We always suggest, as do the detoxes, please go on to a program, at least a 30-day, if not longer, because these drugs are powerful. They really change not only physically, but mentally. Like they always did, but somehow it just, the intensity seems to have ramped up. Sometimes some of our reports are showing these other drugs, which I'll mention briefly. Nitazine is a powerful analgesic that is not even used in this country for surgery, although it would work very well. It's that powerful and that dangerous. So, but somehow it's showing up in the drug supply. There were 4 fatal overdoses in the month of April. I mean, since January, sorry, since January 2025, that just came out in a report. Will that continue? Maybe, maybe not. I think it comes down to what are the easiest to make in the lab with the less, using the less combinations of drugs. Medetomidine is another animal tranquilizer, stronger than xylazine, showed up already in Philadelphia. We've seen a little of it in Connecticut, so you may be seeing that at some point. That's all I know about it. Same symptoms as xylazine, the sedation, the lowered heart rate, but not in every batch is it showing up, just intermittently. Carfentanil, another fentanyl type drug for elephants to anesthetize elephants. That came out years ago. That for some reason didn't catch on, but you might see it here and there. But I have a feeling the xylazine and the fentanyl are just going to stay and always be here. Could I go on to questions now?
Yes, let's go ahead and move on to questions. If everybody can just go ahead and raise their hand, we think that we have the chat fixed. If you have a question, please raise your hand and then you will be unmuted for the questions. All righty.
All right, we do have a question. Can xylazine be detected in a routine drug screen, or can it only be mainly through blood work?
Yeah, no, not in a routine drug screen. And up until recently, it wasn't showing up on any kind of report, even a post-mortem toxicology report. But now that's changed because it's so prevalent. But on a regular drug screen, no. Only because it was never thought to look for it and put it on the screen.
And we have another question. How many clients do you suspect have been exposed to xylazine that you see on a routine basis?
I'm going to the only way to know for sure is to see the abscesses. So about 3/4 of our clients. At first, when I would see clients that didn't have abscesses, I would think I wondered. I thought, well, maybe their bodies just don't, maybe there's something in their body that deters it, or, they're just lucky, whatever. But what I think now is that there are a few dealers who, do not have xylazine in their product, not necessarily by their own choice. I think they're given the drugs from above, from what I understand. And they're not even sure what's in any of them, other than we know for sure fentanyl and the other additives and occasional nitazine, medetomidine, but xylazine is showing up more and more. So that's why I think it's up to 3/4 of the clients. And the only way I know is because, well, number one, the abscesses. Number two, the way they report the high. When they're so deeply sedated that they could fall asleep and do fall asleep standing up. Yes, way back when heroin was pure, when there was heroin, plentiful, people did have a deep nod to that point. They did, but that kind of went away. But now it seems to be back due to the xylazine. And also the crack users, of which we have many that come to the van. We give out, I told you, the safer smoking kits. They report their high is the opposite of what it used to be. Crack being, powder cocaine being an upper, now they're like tired and they want to take a nap. So it's all changed around.
And then another question, would you be able to repeat the names of the newer drugs that you mentioned
Yes,
that are
yes.
similar to xylazine?
Okay, similar to xylazine, the only one would be medetomidine. METATOMODINE, I believe. Stronger than xylazine, but there was an alert sent out, a special alert that we hung up on the van. But again, clients don't know what's in their drugs necessarily. So I don't know that it's going to help them, the alerts, but it helps us, I guess, to be aware. They're not sure yet if the medetomidine is going to cause the abscesses at xylazine. Because it's an animal tranquilizer, likely it will. It just hasn't hit a lot yet. It's just still random supplies have it. Nitazine is definitely coming forward, and that's the one that is an opiate, very powerful opiate, and is showing up more and more. Nitazine.
Sue, on the nitazine, do you know what the morphine equivalent is of it?
No, I don't.
We can look that up.
Yeah.
It's stronger than fentanyl.
Yes, the fact that they won't use it during operations. Can you imagine? They have this drug and they know how, but they won't use it during operations. They still use, morphine or whatever they use here, fentanyl, propofol, but nitazine is that powerful. So I don't know the ratio though.
We have another question. Is xylazine primarily added to fentanyl?
Yes, yes, that's the common. Probably another reason why the heroin doesn't need to be in the picture anymore, because these two together mimic so closely heroin that people actually, until they, find out more about it, actually think that they're getting a heroin high. But what they're noticing, though, is that they need more sooner. So, yes, xylazine does, because remember, fentanyl will last about 2 hours. Xylazine extends it to 3 or 4, but heroin could go on longer back when there was more heroin. With no heroin, that means in 3 or 4 hours, you need some more drugs. So, what was your question? I'm sorry.
Whether or not xylazine is
Oh, the
added to
xylazine
fentanyl.
and fentanyl go together. Yeah. So, another thing about the heroin is when you buy it in the street, a client told us the other day that if you buy a bag of heroin for those dealers that still have a little heroin that they sell, that would be $5. Heroin and fentanyl. If you buy it with fentanyl and xylazine in with the heroin, or just fentanyl, xylazine, it's $2. So the temptation now for those that don't have a lot of money is to buy the cheaper bag. And so even they understand, they're meaning they, the manufacturers or the suppliers, understand that it's cheaper to make, cheaper to package, easier to, and unfortunately, the clients are getting more xylazine in them than they should, and not any heroin anymore.
And then I'm going to pass it on to Aaron Johnson if they want to come off mute. They have a question regarding MAT.
Sure.
Karen, you need to take them off mute.
Aaron, if you just want to type the question into the chat or Q&A, I will get that asked for you. And then also we have another question. Would you be able to provide a list of the new drugs sent over? And then
I could send them to you, Cameron. Is that what you mean? Or
that'll be fine. Yeah, and I can
you
distribute.
mean right now? Because
No, if you could send it to Cameron after the presentation, and if you wouldn't mind sending your slides, I know we had a little bit of a technical difficulty in the beginning. If that's something that you normally share, and we could send out to our participants, that would be great.
sure, somebody in this office will show me how to send my slides to you.
Thank you so much.
Yeah.
Okay. Aaron Johnson is asking that they've seen clients using methadone with their doses going extremely high. Do you know of any better options?
Yes, yes. That's a big, big problem. High doses of methadone. So we have a lot of clients that come to the van to buy drug. I mean to get needles to buy drugs. And I say, well, wait a minute, you're on methadone. I've been saying this for years. But the answer used to be, well, my dose isn't high enough yet. That's when they were like 30, 40, just starting out. But as time has gone on, there are people coming that they're up to 130, 140. And that's kind of like, yeah, it's kind of like amazing. So I can only think that they need the higher dose because when they were using the drug, it's just more of an effect. Aaron, what was your question exactly? Is there an alternative to methadone?
Yes, that's what it looks like the question
Mm,
is.
yeah. Have you heard about I mean, of course, Suboxone. Then there is that once a month injection, um, Vivitrol, but there's a newer one, and I don't know the name of the newer one. I just heard about it, but Vivitrol is a once a month shot that lasts about 28 days and takes away. It's more similar to Suboxone. It's usually given in the Suboxone clinics, actually. It takes away the desire, and you cannot use when you're on it, or you'll get very sick. Methadone's, the problem is you can still use on it, and or at least that's what I'm seeing. Whereas the Suboxone clients, um, I think I've only seen one, and I said I don't understand how you can use on it because I thought you couldn't use, or you get. He somehow manages it. He goes off the Suboxone for a few days to get high, and then he goes back, which is very dangerous because you can go into that precipitous withdrawal by fooling around with Suboxone and straight opiates. But other than Suboxone and the Vivitrol shot and methadone, no, I haven't heard of anything else.
And then here's a question. It might be more for me, but you can also feel free to chime in. But uh, Christina Taylor says, I'm a counselor in Paducah, Kentucky, and have assumed that xylazine hasn't hit this area. But honestly, it could be here. We just aren't testing for it. So there was a xylazine involved fatal case that was reported in uh, a few months back in our area. And so we do have xylazine test strips here at the Purchase District Health Department, as well as test strip instructions. What we have been recommending for our community is to test using a fentanyl test strip first. If that fentanyl test strip comes back positive, then you would test for xylazine. Then you would use the xylazine test strip to test. But also you could
Interesting.
use it if it's based on suspicion, such as like wounds or sedation.
Hmm. That makes a lot of sense. That's interesting because they do go together. And they say that there are no cases of just putting xylazine in it without the fentanyl, when they're packaging it. So that's a good idea because, yes, it definitely has hit Kentucky because of that fatal overdose. And I think I read in one of the things that it's in every state now, not in the high numbers yet. Hopefully, it won't get there. But the idea that fentanyl, it's going to be mixed with fentanyl, and why they're very expensive, those strips, the xylazine and fentanyl strips. Xylazine, they say, aren't as accurate, but it does make sense to do the fentanyl first, unless you see the wounds. Um, yeah.
So a few more questions. We have one from Sandra Otto. Could we use trazodone with methadone to assist in detoxing the patient off of the xylazine? Trazodone is a human tranquilizer.
That's interesting. The only one I read that they use in detoxes for the xylazine withdrawal detox is clonidine. If that's the same, yeah, possibly. That I didn't read about. I only read about clonidine working. I think they're just at such an early stage in this because it just like hit out of nowhere, even though it's been around, like I said, the 2000s in Puerto Rico, probably 10 years ago in Philadelphia, but it never came to a head until sometime in the last year or so in Philadelphia. And now up, so I don't think they know for sure. So I only know about clonidine.
Do you know if there's a test strip for medetomidine testing like there is for xylazine and nitazine?
No, not yet.
Um, and then a few more questions. Does Suboxone do better over methadone? There are clients, this is from Aaron Johnson again. Does Suboxone do better over methadone? Their clients were up to 220 milligrams
Oh
and
my
they haven't
God.
been able to taper down all those xylazine off of xylazine. And then going back to that question, we do have xylazine test strips at the Purchasers Health Department.
Okay, good. Um, what the clients, I can only go by what clients say. When they say I want to stop. Have you tried methadone? Have you tried Suboxone? I'll go down the list. Or have you tried the it's so individual. Some love the idea of reporting every morning to get the bottle, and methadone has worked for them in the past. Or they're dead set against it. No, it hurts your bones. That's that old myth. I believe it's a myth. Destroys your bones, methadone. Um, and they don't like reporting every morning. And then someone else will say Suboxone makes them sick. I've never nauseous. I've never heard anyone getting nauseous on methadone, but Suboxone, a lot of people are reporting that. But again, they don't like the checking in situation, so they try to go to a program. They try to go to detox in a program, and it doesn't work that often. It really doesn't. They're back before you know it, especially in the last year or two with these new drugs, because it's so much harder now.
Okay, and then another question. Um, what did you say again about it being primarily added to fentanyl only, would you say, or have you seen it in methamphetamine also?
Well, what we've seen from the toxicology, what I've seen from the toxicology reports is fentanyl is 98% in every single report. What's intermittent is xylazine, methamphetamine, nitazine, carfentanil. Those are still random. Xylazine has picked up to maybe 45, 50% higher in some areas. See, that's where it gets tricky because New Haven, another big city in Connecticut, an hour away, can be totally different. We get reports from New Haven and Hartford, and they can be totally different. Longmeadow, Mass, which is 45 minutes north, right over the border in Massachusetts, they have a lot of heroin. Why? the whole thing is so hard to, make any statements about because it changes. It depends on the supplier, it depends on the dealers, it depends on who's sending what to whom, when. Um,
The assumption you can make in our region is that we are a heavy meth use
I
region.
would think you would be
And there's
because of your geography, where you're located. Yeah.
that's our heaviest one there, and we know that fentanyl is in meth here. So
Yeah.
that
Okay. At what percentage would you say that you
um,
have fun?
would have to go to the state lab about that. We don't have an exact percentage on that, but fentanyl is in the meth, and if xylazine is mixed into the fentanyl, at the DEA said about 20%, they're seeing it in xylazine mixed in the fentanyl, and we know that fentanyl's in the meth. That I think that it would be safe to make the assumption that there is a risk of xylazine in meth.
Yeah. Oh, yeah, for sure. It's all about profit, use less of it, all the, yeah.
Yeah,
And
it's all stuff.
so, yeah.
This might be again another question that kind of has me in it involved with it, but somebody's asking, do all local health departments have xylazine test strips? So with the Purchase District Health Department, I can only talk about that. I know there's different people from different areas in this webinar, but each of our health centers, so Ballard, Carlisle, Fulton, Hickman, as well as McCracken, do have xylazine test strips, fentanyl test strips, wound care supplies at each of their health centers. Um, I'm not for sure if that is the same way it is up where Miss Sue is or not, but I can only speak about the Purchase District Health Department here.
Well, we get our supplies from the Department of Public Health, and we don't have them. They don't supply any other place other than the needle van. They don't supply like community health centers or anything like that that I know of. It's just, the needle van directly to the clients. But then I've heard, the rumor going around, not among the clients, but among, another harm reduction program that's in Hartford, is that they're inaccurate. There's too many false positives for xylazine. But I take that with a grain of salt. If I see wounds, then I know that it really is true, because those wounds are quite obvious. The other thing about the wounds is you have to ask, I've come to realize you have to ask people, do you have any weird abscesses or any wounds? Because in the beginning, I was only commenting on and helping with ones that I could see, obviously on their lower arm or hand, or in the summer if they had shorts on. But if I didn't ask, when I started to actually ask, not just comment on and say, let me help you with that, I'd ask a random person that I didn't see any in the hands, and it wasn't summer. And I would ask, they would say yes and pull up their shirt, and they had them on their arms, mostly lower, but sometimes upper arms. So that's important to ask because they're not always visible. In the summer, they'll be more visible for sure. But I was just thinking of that as a random comment.
Yeah, I did want to add to going back to the xylazine test strips instructions. So with the false positive that you had just mentioned, we have only we've also been recommended that it's not for testing on cocaine because the cross reactivity with the lidocaine and that cocaine creates that false positive. So we've gotten
Oh,
that
now see,
information
I didn't
from,
get that. Yeah.
yeah.
Okay.
So we've been talking to Dr. Chelsea Shover that is based in UCLA, just to kind of get some information about that as well.
Do you
Have
see, are you seeing xylazine or are you seeing fentanyl, first of all, in the cocaine supply?
um I'm sure it probably is. I can't really answer that, I guess, right now.
I mean, do
Um,
you get cocaine users coming into I mean, is that like a crack a problem?
We have very low amounts of cocaine use in our region.
That
Um,
is fascinating. That's because you have the methamphetamine, maybe.
yeah, yeah, like yeah, if you're gonna pick a stimulant, the meth is cheaper and longer than cocaine is. But we are seeing an increase in cocaine in some of our counties when you look at drug arrest data. So we know that it's upticking, but we don't have any, analysis of the cocaine to
Yeah.
determine what happened.
Okay. The only reason I asked is I was going to suggest that if you see an uptick, continuing, um, make sure they have Narcan because we made that mistake when fentanyl first came out. Within a 18-hour period, about 12 people died with a crack stem, a crack pipe in their hand, some of them. That's why we knew they were all crack users in the north end of Hartford, um, because none of them were provided Narcan, or like I said before, thought they needed it because they're not opiate users. But the idea is, though, you forget that Narcan is for everyone nowadays, even families that have kids that take pills, that kind of thing. But especially the crack, I never related it in my mind crack to Narcan, but now we've had to. That's all.
I have one more or another question I have. So this is from Brian Ray stating, with the low success rate in detox and rehab, what do you think would be the best option to help clients?
Well, if I had $1 trillion, like some people in this country do, but they wouldn't spend it on this, I would open giant farms. I think removal from the area and a purpose, like that idea of, working on some of the treatment centers that are long term where you're actually out in the country doing something. The problem is what I'm seeing is if they don't, I like the idea of treatment after detox, but 30 days is not enough. They need to be removed, from the area to get their mind turned around. It's just such a mental thing, this addiction, as we all know. Calling it a brain disease made the most sense way back. I remember that first comment. Everybody's different. I know people personally that have lived by AA or NA, mostly AA, for 8, 10 years, and that's their answer. Everyone's different. But now I think extra help is needed for the detox portion. Because if you come out of detox and you still don't feel right, you are not going to be motivated to continue, even though you might mentally and it's the right thing to do, continue not using. But it's just so hard. So give them a chance, like figure this. So when they come out, they are like how they were before they started the drug, at least. And then they've got to work on all the mental, parts of addiction. But if that physical is still gnawing at you're not going to continue. You're going to go get high. This is what I've seen. And it kind of makes sense.
Well, it looks like those are all the questions that I have listed in the Q&A feature as well as in the chat. It looks like there are a few county health departments that have been listed in the chat regarding the Xylazine test strip in Kentucky. We did have one more come through. This is probably the last question we can get before we can close. Are you seeing the use of the NET device, NET?
What's that?
I'm going to pass it to Danielle Sipple. I'm going to ask her to come off mute, see if she can explain that real quick.
It is a newer FDA approved device for opioid use disorder. I know that they're using it at Isaiah House in Willisburg here.
Is it
But
a drug or is it
it's a device. It literally, whenever you look at the information about it, it's a groundbreaking device that is and I'm going to butcher how you say this, proprietary, I can't even say it, neuro stimulation therapy is what it's called, but like it
I've
essentially,
never heard of that. Wow.
well, you're going to have to look it up
I
because
will.
it helps reduce opioid withdrawal symptoms within 24 hours.
Interesting. No, I will definitely NET. I'll definitely look it up. I've never heard of it. We need all the help, because everybody's different. Everyone responds differently to
Well, and it gets back to that point you said of the physical piece that it helps decrease that really quickly within 24 hours. And
Wouldn't that be
we're-
wonderful? Then you can get to the real stuff,
yeah,
yeah. Oh, wow. Thank you very much. I will definitely look that up.
you're welcome.
So thank you everybody for attending
Thank
our
you
first
very much.
webinar, part one of the webinar series, expansion webinar series. Um, we everybody that registered should have registered using the email address that got this link. So whenever the next flyers come out for part two and part three of the webinar series, that flyer will be sent out to you as well as the registration to sign up for those. Our next speaker, though, will be on Wednesday, March 26th, same time at 10 a.m. Central Standard Time. That is going to be Dr. Brett Sponseller. He is the chair Department of Veterinary Science with the University of Kentucky, based in Lexington, Kentucky here. And he is going to be talking about xylazine and it's safe for horses and not people. So if everybody would like to join that, like I said, that flyer and information will be sent back to that email address. So thank you again, Miss Sue, for being willing to take time out of your day to present to us.
Thank you. And I'm going to send the slides to you or to Kaylee?
Yes, if you could just send the slides to me as well
Okay,
as a fact sheet, we can get that sent out to everybody as well.
on the other drugs, nitazine.
Correct. Yes, ma'am.
Okay, gotcha. All right, Cameron, thank you so much.
Thank you. You
Send
have a
them
good one. Thank you, everybody.
over.
Thank you.